Are we broadcasting yet? Yes, okay. Anyway, hi everyone, my name is Jeanette. I'm from KSF Nursing Services here in Victoria. I'm a nurse practitioner, I'm an educator, and I'm also an author. And today I just thought I would look at where we are at with our progress for dementia care in Australia, especially. My background is aged care, and I work hands-on in aged care, and my hashtag is I do aged care. So today I just thought, let me discuss where we've been, where we're going, and just make sure that at least we are on track. So I'm calling this topic here 2020 checkpoint. Are we on course with dementia care? So I'll be going back to at least 1978, where the World Health Organization at the Alma-Ata Declaration in 1978 declared that a health state is a complete physical, mental, social well-being, and that is a basic human right for everybody. So this means a lot, especially as we are looking at how healthcare has progressed along the way. Now, I'm posting this. There's also an inspiration that the 21st of September, which is not very far away, is also going to celebrate World Alzheimer's Day. So I think this topic here is within its context in this day and time. Now, a lot of the members of the World Health Organization, after the Alma-Ata Declaration of what health is, they all adopted health for their countries in a different way, depending on whether they can afford or whether they're in a developing country or whether they are a developing country. They've all responded immediately to make sure that at least health is accessible to everyone, and that is a basic human right. Now, Australia has also adopted this ideology, and other world governments, I think they also did exactly the same, where they adopted this concept of health and they tried to strengthen their progress to ensure that there was health for all by the year 2000. There was a lot of talk in 2000, around 2000, towards 2000, about what we are doing with eradicating some of the diseases that can be prevented. What are we doing with immunization? What are the statistics do we have? What is happening with dementia care? What is happening with the cancer? What's happening with the heart surgery? What's happening with diabetes? So there was a lot of talk and a lot of action and a lot of research. A lot of money was actually injected into different projects to find out exactly what's going on and whether we can meet the timeline for health for all by the year 2000. Of which I think if you look at the world today, there were a lot of achievements. So I think we can tick and celebrate that we are on track with regards to that one. After the Alma-Ata Declaration, Australia in 1992 also started looking at a national dementia plan. Okay, because if you say health for all, you mean all. You can't segregate. So Australia looked at the national dementia plan since 1992 until now. It is still active. Everyone is still working on it. there's a lot of research that is going towards developing this plan. At the moment, there's a deadline for 2025 for most of the members that belong to the World Health Organization to submit or to demonstrate what they are going to do with their plan. So 2025 is the deadline. So that's why since 1992, Australia has been actively participating in research for dementia care, including care programs and everything else. Now, in 1997, Australia introduced their Aged Care Act of 1997. Now, the Aged Care Act 1997 was put there so that at least it can then prescribe all the guidelines. It can be the legislation. It can be the binding regulation for every approved provider who is providing residential aged care in Australia. Now, as read with that, we also have the approved provider principles that came after. And I think the latest ones were approved care providers principles of 2014, just at the top of my head. You can correct me if this is not correct. Thanks. Now, if we look at some of the aspects of the Aged Care Act, it is quite prescriptive. It gives, legal obligations for approved providers to care for each one or each and every person that is admitted to residential aged care facilities. And it also binds approved providers that they comply with the accreditation process that at the moment is being managed by the quality agency. So there are a lot of things that are actually legally binding for approved providers that are stipulated in the Aged Care Act of 1997. This also includes all the financials, how they charge the bond, how they charge the daily care fees, what's happening with the funding instruments. I think when the Aged Care Act of 1997 was established, there was RCS, which was Residential Classification Scale, which then later changed to ACFI as we know it now. So you can see that all these funding tools are indicated in the Aged Care Act of 1997 on how they bind the approved providers and their key personnel as well. So anyone who is working there is also legally bound by these expectations of the Act. Now, so one thing that the Aged Care Act maybe did was focus on aged care. But aged care facilities, they also accommodate clients or consumers that live with dementia. So there are residents there that suffer with dementia, but they are residing in an aged care facility. And the Act itself is looking at aged care. So whether that was a discrepancy, we don't know, because other people may argue that, well, the majority of people who suffer with dementia are old anyway. But if we talk about that in this day and time, there's now early onset of dementia. So is that definition still correct, or we need to adjust it a little bit? So with the timelines of that one, I think there's something that needs to happen to make sure that at least there's a distinct dichotomy between aged care and also the care that is provided to clients who suffer with dementia. So that was the Aged Care Act. So basically, if we are talking about timelines, we are now 2020, which is quite a cardinal point to check what's happening with our healthcare system. Because if we are saying health for all by year 2000, by now, by 2020, we expect to have advanced to the next level. But are we there yet? It's debatable. Some people will say we are there. Some people will say, well, we are close. Some other people will say, nah, that's not good enough. So that's why you can find that at the moment there's a lot of information in the media, there's a lot of outrage from the public regarding the care provided in residential aged care, but there are all these underlying systematic issues that need to be sorted out before we can even start to blame anyone on who is doing what and who hasn't done what, because I believe at the end of the day, people do what they need to do and they just use whatever they've got, you know. So you can't blame the system. The Act says Aged Care Act. So any failures that have happened, really, I mean, we just need maybe to work together and look at it with a more positive to say, well, we've noticed that, how do we improve? So then we start to put down some practical methodologies to actually deal with these things practically on the ground, and then we can evaluate whether they are working or if they are not. But I think it is another journey that we need to travel. So, in 2006 and 2007, we then saw the change from the residential classification scale, which is the RCS funding instrument, to the aged care funding instrument, which is the ACFI now. So now, these changes that happened in residential aged care, they've got things that they changed along the way. So I am lucky that I used both systems. I worked in aged care where we used to apply RCS, and I also worked in aged care where ACFI was implemented and we started to use ACFI. Now, I noticed the two things that we lost with the phasing off of RCS, and I saw new things happen when the ACFI was introduced. Now, after the RCS was introduced, there was a lot of talk about, as clinicians, we need to demonstrate what we are doing for the client. So RCS was basically looking at what are the staff doing for the client, and then you can claim. And the assessment itself also required that certain disciplines should tick off the assessments before a care plan is implemented. So you find that RCS demanded a multidisciplinary team to actually meet and look at what's happening with care. And I know that with assessments for dementia patients or people who live with dementia, it was a lot that we used to invest during that time. And I know that in 2006, 2007, there was a lot of implementation of different programs, and I know that dementia care mapping was a tool that we were using at that time. It was researched, I think Dr. Tom Kitwood came up with dementia care mapping, and I've worked with McCarthy Psychology Private Limited, and they were fantastic in coming on site and actually do dementia mapping for the facility and making sure that at least there's a report, there was detail there that you could actually use to then inform your care plan. It was time consuming, it was expensive, of course, but during that time, it was a good investment for you to have a good assessment for this client, because what we strive to do is to make sure that we understand and we provide appropriate care for that particular individual, because there are so many different dementias and they impact different people in different ways. So you can't use one method for everyone. You need to treat every individual on an individual basis. So dementia mapping was great in the sense that it looked straight at the client, spent 48 hours with the client, just mapping, and the reports were fantastic. So when RCS was faced off, that was the end. I didn't see anyone talk about dementia care mapping. Even if you would suggest this to your boss to say, well, how about for the new client, what if we engage this service here to come and assess for us? They will look at you like, how much is that? And you say, well, it costs this much, but it's a good investment. You won't hear. You won't hear, and they'll block you. It was not an option, you know. So with the introduction of ACFI, it then introduced the PAS, which is the Psychogeriatric Assessment Scale, and also the Corneal Depression Scale. So these two tools came also as evidence-based tools to assess under ACFI. But this is an aged care funding instrument. So whilst the tool is being used now, but I think it's about also thinking whether the same tool can be used to assess a client who is living with dementia. I think we need a research or some information search as to whether this tool here really assessed what it needed to assess about that client. Okay, so I'm not going to delve much into that conversation, otherwise we'll be opening another bag of worms, but I just want to point at whether we are still on target or not, because there's a lot of research, and if by 2020 we are well advanced in our clinical practice and medical devices, so our evidence-based tools need to also advance to that level, including in aged care, because we are adopting a mantra that says we need health for all. So a good assessment for a client who suffers with dementia, I think it's a fair go, because they really deserve to be assessed thoroughly and to have a care plan that suits them as an individual, not a schedule that suits the staff or the management. It's not the other way around. So that's me. That's what I think. But I mean, other people beg to differ. But for me, at the moment, it's about focus on what the client requires. Okay. So whilst we are talking about all these tools and all this system change from RCS to ACFI, now there was also one aspect that was not addressed. So the personal care workers, and these are the majority of the staff that work in residential aged care. Now, at the moment, there was no formal qualification for their training so that they can understand dementia care or dementia programs, or to even understand the condition itself because of its complexity. So a knowledge gap has gone on for so long that there was no proper education for the PCAs. So they come in with certificate 3 or certificate 4 in aged care, but there was nothing focused for their study for dementia care. However, they can have in-service or online training about dementia care, but I don't know whether in-service or online education can really give people that platform of understanding and practicing and being checked on whether you've done the right thing or whether your client is actually responding. It's very involved. So that knowledge gap there, I think it has been there for quite a while, that no one understood what they were doing, but they've got a responsibility to look after this client. So maybe that's why now, from 2018, 2019 until now, there's this outrage by the public regarding what they are saying, the poor care in residential aged care facilities. Is it the knowledge gap that has been there for so long? Is it the loss of appropriate tools? So it's very difficult to pinpoint as to what has gone wrong or what is actually worked. So at the moment, I think it's about focusing on what we need to achieve in the future. And the University of Tasmania took their first students, I think this year in 2020, to actually study a bachelor in dementia. And there's also a bachelor in aged care. So aged care specialization has always been there. It has always been there, but it was at postgrad. So you do your nursing, when you finish your degree, then you go and do your postgrad in gerontology. So it has always been catered for. But the dementia care programs, I don't know how the Australian qualification framework hadn't closed that gap as yet, but I'm glad it has happened now. We've got people who are now studying Bachelor of Dementia. Very soon we'll have a Master of Dementia, and then we'll have other, programs that are going to come along. So with that regard, I can say, yes, we are on track, because now we are going to start closing that gap. That knowledge gap is going to be closed. Because once these new graduates, when they finish their degrees, they will then come and guide us. They'll guide everyone. So I think it's something to be excited for. We know that everyone can't wait. We are very impatient, but at least it's happening. We can't say, oh, it's not happening. It's here now. It's here now. Okay. So, but in the meantime, for those who still need input, the Dementia Behavior Management and Advisory Service is still available for those services that still need to engage them and get guidance and assistance in setting up dementia programs. And I know that when I was working at another service, we established our own dementia care program, and we invited people from Dementia Australia to actually come and teach us. They invested a lot of time, and staff invested a lot of time, and families also invested a lot of time, and we were following the Montessori person-centered care type of value, and it really worked well. So I think it's about putting in the effort, but it really depends on, like, if the vision of that service is geared towards that sort of a program, because a lot of them, they've got visions that don't align with dementia care. So you can't do anything about it because it's not even in their vision. Although they accommodate people with dementia in their facilities, but their vision doesn't align with providing appropriate assessments for them. But I'm glad that I was part of that project, and I participated. We all got some certificate of attainment, and it was just a proud moment to know that we are getting certified from Dementia Australia on our work that we had done at this particular service. But I'm not sure whether it's still happening now, because sometimes when management change, they also come with new ideas, and then they phase these things out, and then they bring another thing, or they can say, well, that's a total waste of time, we won't do that, we do here. But it's all good, because you know, each for their own, but it's about the care. That's my focus. All right. So after we talk about the funding instruments and everything else, the knowledge gap, now in 2008, there was a lot of shift towards the global financial market. So residential aged care facilities in Australia were also opened to the global financial market. And this meant a lot of changes that happened. So far with our pace, we're going forward, and then we're coming backwards. And then we move forward, and then we go backwards. So whether this move was the correct move or it was not the right move, I'm not sure. I cannot judge that. As a clinician, I don't think it's my role to be looking at financial, you know, like the global financial market. But it happened anyway. So some of the facilities, yes, they started appearing on the share market as well, competing for their shares to be bought. And there was a lot of influx of foreign money coming in to sponsor or upgrade or buy more or expand or make things bigger and wow in residential aged care facilities. So we don't know whether it was only the buildings that they improved, and then the care, we don't know what was happening to the care at that moment. But at the moment, we now know that there's been a lot of discontent and a lot of unhappy expressions, you know, in the media from the public. And, you know, I'm not sure whether this one was the right move or it wasn't. But I mean, when it brings profitability, it can be good, because then there's a lot of work for people to do, you know. So there are always the pros and the cons, but we don't know which one works for the client, because as clinicians, we are always there, right on the forefront, hands-on with the client. So that's our focus. So we don't know whether all this was good for the client that we were looking after. So the opening of the residential aged care facilities to the global financial market, we also saw a shift in some of the names of the positions that we occupy, you know. So previously, if you are going to be the in charge or the manager or the boss in a nursing home or residential aged care facility, your title was director of nursing. I worked as a director of nursing. Right? That was the name. Why director of nursing? Because you need to be a nurse to be a director of nursing. You can't be a director of nursing if you are not a nurse. So, this title changed from director of nursing to facility manager. Now, facility manager is open. So the opening to the financial global market and the opening of the position, so everything was open. So you don't know. So nurses can apply to be a facility manager. A hairdresser can apply to be a facility manager. A chef can apply to be a facility manager. Anyone with business skills can apply to be a facility manager. So this was the new trend from 2008. Director of nursing, you're phased out. And it was very complicated. It was so difficult for people who have worked as director of nursing to survive in that change, because you wear a cap as a director of nursing, and what you are representing are your clients and the staff, and you've got how you manage the staffing, you've got how you manage the acuity of your clients, you've got how you are managing nutrition for your clients, you've got methods of managing continence. But as a facility manager who is not a nurse, all these things are not a priority. And the person you report to is coming from head office, and they're called a partner or a business manager or a regional, all these fancy names that come from the head office part of it. And then this person here doesn't need to be a nurse. And then you've got a clinical manager who reports to a person who is not a nurse. I mean, that hierarchy is quite complex in how it works. And I never understood how that actually works. How can a nurse report to someone who is not a nurse? Like, is it even? So that then inspired my book, Rewrite EBIT. Because in the places where residential aged care facilities have been open to the global financial market, there's a push for profit. So one formula that is widely used in Australia for residential aged care facilities is EBITDA. So EBITDA is focused on profit. So that's why I wrote that book, to say, well, you know, quality care needs to be part of that EBITDA. You throw in a bit of quality care in the EBITDA, then I think everyone is well balanced. The profit is there, the clients are looked after, so at least there's equilibrium in there. There's a balance. Okay, so that then inspired the book that I wrote. People thought, oh, she is mad, but that's okay. That's okay. Okay, so we saw the change of name from director of nursing to facility manager. And we also saw the change of the staffing levels and the rostering. Under facility manager, it was the first time ever in my life to see a roster where morning shift starts at 7 o'clock and they finish at 3 o'clock, and the afternoon shift starts at 3 o'clock and finish at 10 o'clock, and the night staff start at 10 o'clock and finish at 7 o'clock. These people are crossing each other at the door. These people, these staff, they are crossing each other at the door. You start at 7, the other one finishes at 7. So you cross at the door. The only overlap that was allowed is the in-chargeness and the other in-chargeness. They're the ones with 15 minutes to hand over to each other. 15 minutes to hand over this big facility, including the checking of the Schedule 8 drugs. 15 minutes. So for those with ears, you can hear me. So what's happening to that person who's been left sitting on the toilet? And because they can't remember, they don't know how to push the buzzer that they are ready. But they've got a body memory of walking. But in this time, they can't walk. Staff have already gone. Other staff are coming in. So people are left unattended. People are left with no supervision. People are left with no one. In that period of change, they are left unattended. So they fall, or they go into other people's rooms, and then the other one will punch them. So that's why there are all these stories now that we see that they are coming up. You know, this person went into that room and they whatever happens, you know, it's because they are not being attended. But then on the hindsight, the same facility is claiming through the aged care funding instrument that we are supervising the staff. We are supervising the clients. You are claiming supervision. But there's a time there that no one is attending anyone. So that's just my observation. And this is wide. I think you can hear from the Royal Commission reports that this goes on widely at a very large scale in Australia. I'm not talking about any particular state. I'm talking about throughout Australia. This is happening. So the timelines of staffing, we're still behind. So we need a bit of improvement, or we need something to happen so that at least these ones don't continue to happen. Okay. So we move to 2009. Now, in 2009, with the introduction of residential aged care facilities into the global financial market, a lot of local government authorities who owned residential aged care facilities could not compete. They couldn't compete because local government budgets and local government systems could not cope with this much change, with the competition, with all the mansions that were coming up. There was a lot of competition. So they said, well, according to our legislation, we can't compete for profit because the market is now open. So they bowed out and they sold most of their facilities to private providers. You know, there was a lot of talk in the newspapers, and there was a lot of disgruntlement, but this is the background of it, that local governments cannot go on the global financial market and compete for shares. That's not part of the legislation, and it's not part of the expectations. So this is why they had to sell their residential aged care facilities to private providers. Okay. All right. So after 2009, I'm going to jump on to 2014, because a lot then has been happening between 2009, 2010, 2011, a lot of competition, a lot of, like big facilities being built. Now they hold 140 as a minimum sometimes, and then they've got 20 beds or 30 beds or 15 beds that are dementia specific in this big hotel looking like facility. And it's good. It is good that at least the environment was improved that way. And it was great when you bring your loved one and you say, well, we are looking at this place here for you. It looked nice. And even some of the families, they were proud. Oh, my mom is in that one. That one, the one, the one looking into the ocean. Yeah, that's where my mom is. So it was really, really good to improve those facilities and the whole outlook. But I think for us clinicians, I'll repeat, our focus is on the care for the person. Right. 2014. The approved provider principles of 2014 were reviewed and re-established, right? And these principles are legally binding for residential aged care approved providers, because the aged care principles set out the legal obligations that the approved providers have for each and every client in their service. You can't say, oh, we look after this one. Oh, no, we can't say. No. If someone has got a complex wound, you need to bring in a wound consultant, a wound specialist, to come and have a look at what's happening with that wound. If someone needs a particular item or a particular tool or a particular cushion, you need to get that cushion for that person to sit. If someone needs a recliner chair, which is an air form of a chair, you need to go and get that, because that's what the occupational therapist has recommended for their skin type and for their bone prominences. So all these legal obligations are out there for approved providers, including all the various legal requirements for them to follow as part of their practice, including their key personnel. Okay, so I'll go back to the combination or the co-accommodation of residential aged care clients and people who live with dementia in the same facilities, using the same tool to assess them, using the same financial or funding instrument to claim for care money. Now, the World Health Organization made it very clear the definition of aging, that it was advancement in years, a chronology of years from young to old, and it's a natural, normal progression of life. And they also looked at defining dementia as a syndrome due to diseases of the brain, usually of a chronic or progressive nature, affecting higher cortical functions of memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment. So, if we are going to get people who live with dementia and people who are aging live in the same environment, so that's what I'm calling the co-accommodation of these two cohorts, then you need to be able to provide the appropriate care for those clients. Dementia care, aged care, there's a dichotomy, there's a difference between the two. From these definitions, each one of them stands as a specialty. Aged care is a specialization, dementia care is a specialization. So you need your staff to have at least a double degree. You need your staff to have a double degree in aged care and dementia care. Thank goodness. University of Tasmania now, they've got that double degree. So this is the expectation. If they are going to be in the same facilities, then the staff need to have an equivalent of knowledge so that at least they provide the appropriate care. Okay. So, looking at where we are at the moment, the timelines, I think we are still on schedule. We are on schedule because the University of Tasmania is now offering that qualification, you know. So it's happening, it's there. We just have to wait a bit longer at the moment, but it's a reality. It's tangible, it's achievable, and it's happening. Okay. Now, I'll go on to 2015. Now, in 2015, Australia revamped its National Framework for Action on Dementia. They called it the National Framework for Action on Dementia 2015 to 2019. So we are still on target. Since 1992, when they did their dementia, the National Dementia Plan, until now, we've got the Framework for Action on Dementia. So I think we've traveled very well in that continuum. And it's only last year, 2019, that they did the final touches on this framework. And I think very soon we are going to have the practical methodology being rolled out as to, you know, what we expect to present in 2025 when all governments that participated in the WHO campaign for dementia care are going to actually demonstrate what they have done with their framework for action on dementia. So for that one, we are on track. So we are going now to 2017. 2017, the World Health Organization are talking about a global action plan on the public health response to dementia 2017 to 2025, right? So the World Health Organization is looking at all these global action plans. This is why I think as Australians, we might think we are on our own. No, this is a global thing, and every country that is participating is preparing an action plan on how they are going to make sure that at least there's appropriate care for people who suffer with dementia. Okay, so with this global action plan, it's scheduled for 2025. So that is our cutting point. So if we're going to do another timeline, we'll do a timeline from 2017 to 2025. And I think we can see how we are tracking. There's a lot of research now. There's a lot of advancement in all the different technologies. We've even got robotic tools that can be implemented in dementia care programs. So I think it will be fascinating to take that journey, to actually look at what the progress has been from 2017 to 2025. I'm getting excited already because there's a lot that's happening, and like, people are working very hard. So yeah, I like to see things moving. I like action. I like to see things progressing. So and participating in such a platform would be fantastic. So we'll see what the future holds for us. Now, in 2018, the World Health Organization published the technical guidance and recommendations for developing national plans on dementia. And now, this happened in 2018, not very long ago. Was it on schedule for the World Health Organization to establish these technical guidelines? Yes, because from 2017, we've already moved it to 2018. We now got the technical guidelines, So we are moving on schedule. But then what happened in 2018? 2018 was also received with a lot of public outrage for residential aged care facilities. The investigation by Four Corners into aged care brought in a lot of, discontent with what was happening in residential aged care. And then there was the Aged Care Royal Commission, and if you follow, some of the evidence that was given as part of providing information to the Aged Care Royal Commission, I mean, it was undeniable that, of course, some things had happened that were quite not right, but it's about time to also reflect on all these aspects that are underlying, because there's a root cause of everything, So there was a lot of reaction from the public, of which I acknowledge, I deeply acknowledge. Some of the footage was really, really, it was shocking. You go home, you don't eat any food, because you can imagine, like, if the camera was not there, what could have happened to that person, So it is what it is, but I think we are also moving in the right direction as a nation. So if you look at the response now, to the COVID-19 pandemic by residential aged care facilities, it has also triggered a lot of news feeds about, oh, this happened and this happened, and so the disgruntlement is still happening. It is still there, you know. So there's a lot of work to do, and it's not about residential aged care facilities only. You know, it's about all of us, you know, it's about everybody getting involved and helping them. The knowledge gap has been for a long time, like if we can track here, that the Bachelor of Dementia has just been something new. So there's a lot of knowledge gap there that was allowed to continue over a long period of time. So that's why it's bringing us now to this period where everyone is outraged about what's happening in residential aged care. So I've already spoken about the University of Tasmania and other providers. I'm only concentrating or focusing on that program offered by Tasmania because of the way they've actually arranged or organized some of their content and their subjects and their units. I'm quite impressed that we are going in the right direction. Now, I don't know about you, but I believe that Australia is still on track. A few delays here and there, just like any system. If you say system, not every system works perfectly, because a system joins in with the process. So if you look at the digestive system, if you look at the cardiac system, within that system, there are so many steps in the system that can go wrong and cause a blockage. You know, you might eat the wrong food and then, you know, or things happen in a system. So we've got a system, we've got to own it. We've got to acknowledge the wrongs that have happened. We've got to acknowledge also the progress that we have traveled. And we've got to acknowledge the research that is there. And we also need to acknowledge that for us not participating, we have just sort of abrogated our responsibilities for someone else to do. So if you leave someone else to do what you are supposed to do, you can't blame them that they've done the wrong thing. So I think we just need to join hands, each and everyone, to approach this, you know, dementia care, especially in residential aged care facilities. We need to approach those topics with a bit of awareness that a lot has happened along the way to get us to where we are at right now, you know. So with this checkpoint here that that I'm calling the 2020 checkpoint, are we on track with dementia care? I think you can see in the discussion that a lot of things have happened along the way, and anything new that comes causes a stumbling block. Sometimes it's a stepping stone. It is what it is sometimes, but it's about also knowing that there's a lot of willingness, especially from the care staff, from the nursing staff. You know, like I've never seen a clinician who picks a client. We look after each and every client, and we do our best as nurses and care staff and doctors and, you know, the multidisciplinary team, including our dietitians, including our occupational therapists, our recreational therapists, our activities, physiotherapists. There's a lot that each and every discipline has put into it, you know, including some of the psychiatrists and the consultants and some experts. They've all put in something in there to make sure that at least we improve our care. So it's not all bad, but the most important thing is where we are going. I think we are heading in the right direction. Okay. Now, this 2020, we have the International Dementia Conference. You know, it's happening via virtual. The theme for this year is Care in the Age of Outrage. I think they are spot on with the care, with the theme, Care in the Age of Outrage, you know. So it's good that we get feedback. Not every feedback is good for others, but I think if you look into the feedback, although people might not like it, there's something to learn in every feedback that we receive. So the theme this year for Care in the Age of Outrage, I think the International Dementia Conference is spot on. We are caring in the age of outrage. It's not always going to be easy. People are going to be critical. People are going to be very analytical about what you're doing and what you haven't done and things like this. But it's also good to acknowledge that the clients that we are looking after are also knowledgeable. You know, there's a lot of information and people are aware. People can Google and they can find information. So I'm also going to encourage, you know, my colleagues, whatever discipline you are, to also make sure that you are up to speed with your own self-improvement. You know, there's a lot of things that we can do to self-improve, because we've got to run, you know, with the change. We've got to run with the progress. We've got to lead the progress, you see. So if we are right at the forefront and we've got the right knowledge and we are confident, I mean, we'll do the best for our clients, you know, because the industry needs clinicians. It needs each and every one, each and every discipline, you know. So we are there for that. And so let's make sure that even if we're being criticized, it's good to acknowledge. And even if you've got to apologize, you know, don't feel bad to actually say, well, I'm sorry, I didn't understand that. I will improve, and thanks for bringing that to my attention. And you then make a genuine, you know, effort to improve. Because where there's a genuine effort to improve, then you can see that, oh, the person has improved. Actually, they didn't take a beef about being corrected about something else. And I think if we carry that attitude, we make, you know, things easier for us and for everyone else that we work with. So before I finish this, I've got a few recommendations for the future, as well as, you know, put my contribution towards the practical application methodology, which I call the PAM. Okay, the practical application methodology is about looking at what we can actually do to make sure that things will improve for the future. So I'm just going to list some of the things that I think about, you know, looking at where we've traveled, looking at what has gone wrong and what is disappointing the public about the care that we provide. And so I've just listed a few things that are quite suggestions. These are suggestions. So the first suggestion that I would look at would be to establish appropriate assessment tools that assess the type, the stage, the prognosis of the dementia in order to provide appropriate care for that consumer. So we need the correct assessment tool. You know, we just need to make sure it's appropriate for dementia. Number two, establish a funding tool for dementia-specific services. it needs to be a separate funding too for dementia care services, not the same one as ACFI. Number 3, to establish a standard configuration of relevant and appropriate multidisciplines ideal for the assessment, formulation, and contribution to care planning for dementia care facilities. We need to know who is going to sit in that multidisciplinary meeting where we talk about an assessment, where we talk about care planning. We want to know which expertise do we need to be there that are relevant and correct for what we are looking at. If we need a psychiatrist input, we'll have a psychiatrist. If we need a neuropsychologist, we'll put in a neuropsychologist. If we need a geriatrician, we put in a geriatrician. If we need, so whoever we need to standardize the configuration of relevant, appropriate multidisciplines that need to be there when we do assessments for dementia care planning. Number 4, we need to improve regulatory compliance structures. At the moment, we've got the quality agency that are, looking at the practices, and they're looking at whether the residential aged care facilities are complying with the legislation, with the Aged Care Act 1997. Now, we also need a similar group, but we need this group to be highly specialized to monitor regulatory compliance for dementia-specific care. It needs to be a separate group that is looking at dementia-specific care so that there is no mixed bag. Number 5, we need to establish a dedicated binding dementia care principles. They've got the aged care approved provider principles. We need similar principles that bind anyone who is going to be giving care to any person who is living with dementia. So these principles will outline the regulatory compliance obligations of the aged care approved providers who also provide dementia care for a more focused surveillance. We need a more focused surveillance to monitor residential aged care facilities if they are going to continue to host or co-accommodate clients with dementia. Number 6, the government to consider a dedicated commissioner for dementia care, or it could be a chief nurse, okay? A chief nurse that will lead the group of dementia care experts so that at least they will look and they work very, very closely with facilities that are providing dementia care, so that at least they ensure the dementia care focused programs and models of care implemented in those facilities are appropriate. They are functional, that they are being reviewed, and that they are changing as the person changes, because dementia is a continuum. When the person changes, we need to see that their programs will also change. It doesn't remain the same. Number 7, to consider various types of suitable accommodation. Okay, so at the moment, it's at home or in residential aged care facilities. Now, I think it's good to also explore into other methods, into other accommodation, whether it's a small cluster, whether it's a small facility, whether it's a 5-bed house. Only 5 people can be there. So, depending on whichever way, I think it's good to have a project where all these suggestions can be implemented, and then establish all these various types of facilities, and then review as to how each and everyone is performing, as well as taking into consideration the response from the person who is suffering with dementia, including their family. Because some people like to live in a big home, some people like to live in a tiny house. So you'll find that even when they are older, even when they suffer or live with dementia, these needs remain the same. You can't be putting a person in a very big place where they don't know anyone, and you expect them to be normal. No. So it's about looking at what are the particular needs of this one, and then giving them the appropriate accommodation. Number 8, to provide appropriate dementia-specific clinical placements for university students undertaking the Bachelor of Dementia. Isn't that wonderful? You know, they come for placement and they start to actually work, implement programs and learn. And, you know, I'm excited. I'm really, really excited about this and looking forward to how this is gonna, you know, pan out. You know, I can't wait. That's my response. I can't wait because I'm feeling good about it. Number 9, residential aged care facilities may need to offer scholarships, right, to their staff. These staff have worked in aged care for so long. They've got the experience. So they can be given scholarships to actually go and do dementia care courses, or even do the bachelor. How about that? I think it will be a very, very good turnaround for facilities to actually undertake this part of, you know, improving their staff, you know. And number 10, to establish a link between universities and facilities that provide care and accommodation for people living with dementia. Isn't that wonderful? That a facility can say, we've got a relationship with this university, and those universities, they can actually organize that they donate part of their EFT, whether it's a half a day, to come actually to the facility and work at the facility and have some input into these dementia care programs, as well as educate some of the senior staff, like the nurses, the clinical managers, and have that link between, you know, the facility and the university. So you are feeding in information, and you are also getting, you know, opportunities for more research, because you are working in an environment, you know. So things like that, or it could be a secondment. I'm just putting it out there to say, well, it could be something that can happen in the future that will make us feel all excited about, you know, working in aged care, and also linking with universities, so that at least there's this ongoing cross-pollination of information between the university and the residential aged care facility or the dementia care facility. I'm sorry that this topic took a while. It took a long time, but I just thought I would put in the timelines and do the 2020 checkpoint, so that at least we see whether we are on track or we are not. But I think from where we can talk from now, there's a lot of progress, and I think where we are going by 2025, I'm expecting a lot of progress to move in that direction. And I'm also hashtagging IDC 2020, which is the International Dementia Conference 2020. for this year, because some of the key speakers that are on the list, I mean, I can't wait to hear, you know, what they're going to talk about or what they're going to say, and just having these ideas and having these links, or even get in touch with some of their work, so that at least we can also improve our work. I think this is the most beautiful thing about academia and being an academic. You are not afraid to go and say, teach me more, you know, and then we share that knowledge and improve the care for our clients. And I don't think we are too old to learn. I think everyone should have an open mind, just be an open bird, you know, ready to get information. And I think new information refreshes us as clinicians, and we jump on to go and then put it into practice, and then evaluate how it's working, and then give a report. And so things like this, I think they're quite wonderful. So that was my talk then today. Quite long, but I just thought I would give the checkpoint, because there's so much outrage, there's so much, but I think behind the scenes, people did not know that there's been also a lot of changes, you know, in the meantime, that have resulted us to being here. So I think it's about, you know, looking at what has happened. I was reading an article on aged care insight, and there's an article there that is asking, where did the billions go? Like, the government has put in so much billions of dollars in residential aged care facilities. Where did the money go? So topics like that, people are starting to ask questions like, where is the money? Like, what happened? So it's to do with, you know, people who are actually starting to genuinely want to know. And please be part of that conversation, you know, be part of that group. I don't want to take much of your time. Thank you everyone for listening. My name is Jeanette. I do aged care, and this year I'm hashtagging IDC 2020. I'll see you there. Thank you. Bye for now.